All right. I'd like to welcome everyone. We are going to be talking about zygomatic and pterygoid implants in full arch immediate load reconstruction with dehydrated human deepithelialized amnion-Chorion. So basically what I'm going to be talking about is using BioXclude in zygomatic and pterygoid cases. Here we are. I remember 1 year ago, we were about ready to lecture at the Academy of Osseointegration meeting in March of last year. And right before that was supposed to happen, COVID popped up and everything got canceled last minute. And here we are a year later. And unfortunately, we're still doing all this virtual stuff. Well, we'll make the best of it. And we'll hopefully get some good education today. So let's go ahead and talk about Amnion-Chorion, zygos, and pterygoids. All right, a lot of the information that I'm going to be talking about today is in a book that I published towards the end of last year. It's called Pterygoid Implants, the Art and Science, available at pterygoidimplantbook.com. A lot of the stuff that we'll talk about today, you'll find in this particular book. All right, so what we're talking about is, in our office, we call it DIArch. Other companies call it, various different names. What we're talking about is immediate loading of a teeth in a day style protocol. And with this, what we have is a minimum of 4 implants used to support an immediately loaded fixed prosthesis. And typically, these are loaded within 2 hours or so, depending on your office. Some people deliver the next day. And the posterior implants can be angled, sometimes up to 45 degrees, sometimes different angles, depending on the anatomy. And the reason for the angulation is to avoid the maxillary sinus, to avoid anatomic structures such as the mental foramen, the inferior alveolar nerve. There's other reasons for angulation, using longer implants, getting more bone-to-implant contact. But essentially, we're angling some of the implants, typically the posterior implants. And it has immediate function. That is the hallmark of this. It's immediate function. So we're taking a situation like this. On the same day, we're turning it to something like this, and we're loading. And there's various different protocols. You can put 4 implants, 5 implants, 6 implants. A lot of times it's referred to as all on X at this point. So we know that full arch immediate load works. How do we know this? Well, we have 20 years of published data. 20 years of published data that this technique works. We look at, there's a number of studies. This was the first studies published by Malo. Malo has a number of studies, pioneered this, really made this mainstream treatment for the rest of the dental industry. A number of other studies have been published by different authors from all over the world, different implant systems, different restorative techniques, different protocols. But what we have found is that the implant survival is very high. Typically is 97 to 99%. And the prosthetic survival is very, very high, typically close to 100%. Why do we have such high survivability? Well, we have cross-arch stabilization. We have implants designed that have very high insertion torque, a number of reasons. And if full arch immediate load works, why do we need zygomatic and pterygoid implants? If we have 97, 98, 99% implant success rate without pterygoid and zygos, why do we need them? Well, let's take a look. Reasons for zygomatic implants. Well, we need prosthetic support for severe maxillary bone loss. So you have these patients that come in your door, they've been in a denture for 20, 30 years, there's just no bone left. We have patients with failing implants that have no bone left. We want to avoid bone grafts in some of these patients. And in some of these patients, even if we do a bone graft, it's not going to get the patient to where we can place a strong implant to support an immediately loaded restoration, or any restoration for that matter. Zygomatic implants can allow us to avoid sinus lifts. And sometimes we do need to avoid sinus lifts, whether it's sinus pathology, previous sinus lifts that have just ruined the sinus. Schneiderian membrane is like Swiss cheese. Sometimes sinus lifts just aren't going to work as well. And as we know, when you do sinus lift, regenerated bone, it tends to be of a type 3 quality in most cases. And zygomatic bone is definitely much, much denser and harder than bone we can generate with a sinus lift. Zygomatic implants can be used as a rescue implant to bail you out of certain situations, to rescue failing cases. They come in handy in a lot of scenarios. Branemark was, again, pioneer of titanium implants in the mouth, period, but also a pioneer in zygomatic implants. And Branemark had a quote in regards to zygomatic implants where he said, "Mother Nature has provided an area of dense and extensive bone near the area of the jaw, which can provide good anchorage prognosis." And initially, Pierre Branemark, he was using these for, cancer, reconstruction patients that had severe amounts of bone loss. And, we needed some bone. And, Branemark found this bone in the zygoma. It was one of the first people to utilize this dense area of bone, as he mentioned, near the mouth. So what about pterygoid implants? What are some reasons that we would want to use a pterygoid implant? Well, again, for additional support. Increase composite torque value, which we cover in many other lectures. We'd like to ideally get 120 Newton centimeters of composite torque value. Many times with zygomatic and pterygoids, we'll get significantly higher than that. Pterygoids can allow us to improve our anterior-posterior spread, AP spread, for prosthetics. It helps to eliminate cantilevers. Cantilevers, in most cases, never produce anything good. If we can eliminate them, it's all the better on our prosthetic end. So pterygoids, when you have that implant, you eliminate the cantilever. It allows us to avoid sinus grafts. And we mentioned, some reasons why we would want to do that when we talked about zygos. It can be an alternative to zygomatic implant in certain situations, not all situations certainly, but in certain situations, a pterygoid can be an alternative to a zygomatic implant. And like a zygomatic implant, pterygoid can be used as a rescue implant. And as a rescue implant, I'd say even more so than the zygo. Pterygoids are very easy to place, they're very fast to place, and they can bail you out of a lot of situations where utilizing a zygomatic implant may not be totally necessary and would be a bit more invasive than placing a pterygoid implant. So how do you choose between the zygomatic or a pterygoid dental implant? Well, my personal philosophy, and this is just me, I do a lot of these cases, this is the bulk of my practice, is just pterygoid and zygomatic implants. I will place a pterygoid without a zygomatic implant in a situation such as this, and I call this the FAST technique, pterygoid fixated arch stabilization technique, in which we're utilizing pterygoid implants to increase AP spread, eliminate cantilevers, increase composite torque value, and when I do this, I don't need a zygomatic implant because in this particular situation, we had enough bone in the premaxilla to place a standard all on X style, all on 4, all on 5 type of implant protocol, but we're placing pterygoids in this situation to, again, get the benefits that I discussed previously. Now, if I am placing a zygo, I will always try to place a pterygoid. So I won't place a zygo without a pterygoid, unless I try to place a pterygoid and it doesn't go to place. And so for my zygomatic cases, if I'm doing a standard zygomatic case, it'll look something like this, where I have my zygomatic implant, and I'll always, in most cases, have a pterygoid implant in the posterior to help the zygomatic implant. And if I'm doing a quad, I do the same thing. So what is the rationale for me using pterygoid implants to support zygomatic implants? Well, zygomatic implants are reserved for patients that have severe bone loss scenarios. So we already know that there is a lack of bone in these patients. So if we can get more support, all the better. And there is no harder bone in the oral area, especially considering the maxilla, than the zygomatic area, the zygoma, and the pterygoid complex. Both very hard, dense type 1 bone. Pterygoid implants can eliminate cantilever action on the zygomatic implants. Zygomatic implants are already a very long lever. And if you're now attaching a cantilever onto that long lever, you have a lot of torque onto that implant. And so if we can eliminate the cantilever by placing pterygoids, we take a lot of pressure off of that zygomatic implant. Also, pterygoids can assist the zygomatic implant absorption of heavy posterior occlusal forces. So we know that the highest force that we generate in mastication is in the posterior maxilla and the posterior mandible. This is where we have our molars. This is where we do the bulk of our grinding. And this is where we have the heaviest occlusal forces. So if we could put a very strong pterygoid implant back there to assist the zygomatic implant in this area where we're going to have the heaviest amount of occlusal forces, then that's another reason why I'm placing this. Another reason that I'm placing a pterygoid implant in relation to a zygomatic implant is it also allows me to significantly increase the AP spread. And it also allows me to increase the composite torque value, which, if we're placing a zygomatic implant, we're already getting a significant amount of torque with the zygomatic implant, and having a little bit more with the pterygoid, all the better. So how do we choose between a zygomatic implant or a pterygoid implant? We'll look at a couple of cases here. So this case, we had a patient with severe bone loss. We could see not much bone left under the nose subnasally. We have sinus pneumatization. We have a few teeth left on the right side. Some of them have been root canal treated. And this is the plan for this patient. Because they're missing a significant amount of anterior bone, I'm planning a quad zygo. And again, anytime that I am placing a zygomatic implant, whether it be a standard zygo or a quad zygo, I am placing a pterygoid implant. And so let's look at this. We have severe bone loss in the anterior, and that's why we're planning for a quad. We have severe bone loss in the posterior. We have pneumatized sinuses. We have quad zygo planned because there's no anterior bone. And the pterygoids are going to provide posterior support to the zygomatic implants as we discussed previously. So we have the patient look like this, and when we treated her, she ends up looking like this. You see we have quad zygomatic implants, and we have pterygoids supporting the zygos. All right, let's look at another case, zygomatic or pterygoid implant. So in this situation, we have a bridge that has failed. We can see a lot of infection around some of the teeth. We could see lack of anterior ridge where this patient had this long-standing bridge. We can see there is some premaxillary bone. And so in this case, I'm planning something like this. I can still place some implants in the premaxilla. So I don't need a zygomatic. I certainly don't need a quad. And because we can have this bone in the premaxilla, if I place some pterygoids in the posterior maxilla, I can achieve all the benefits that I mentioned previously with pterygoid implants. Increase AP spread, increase composite torque value, elimination of cantilevers. And that's what we did for this patient. We have less severe bone loss in the anterior. So again, no quads needed. We do have pneumatized sinuses, but not too bad. We can still place standard implants in the premaxilla. And the pterygoids are going to give us the support that we're looking for. And so this is what we end up looking at. Just the pterygoids. This is the FAST technique. No zygos needed here. All right, another case, zygomatic or pterygoid. And this is an edentulous patient that comes in. We see these quite a bit. Sinuses have been pneumatized. We have some beginning combination syndrome. Bone tends to be not quite as dense in these patients that have complete edentulism in the maxilla. And so I'm planning something like this. I do still have some bone in the anterior maxilla. Because that bone's not quite so robust, and because it's edentulous and is not going to be quite as dense, I'm going to place zygomatics. And then if I'm placing zygomatics, I'm also going to go ahead and place pterygoids. So we have severe bone loss in the posterior, pneumatized sinuses. We don't need a quad because we have some bone in the anterior. And the zygomatics are going to get some support from the pterygoid implants. And so we end up with something that looks like this. Again, standard zygos, a little bit of bone support in the front, and some pterygoid implants to support the zygos. Okay, I think this is our last case of zygomatic or pterygoid implants. Now this is something that you may see in your office, an older all-on-X style case that comes in. This case has been in function for many years. And we have a failed posterior angulated implant. And this implant, has failed. And so with this failure, what are our options? We can shorten the restoration, we can graft, with sinus lifts, let that heal, come back later, place implants at a later date. We have to put the patient in a shortened restoration where when she smiles, she might show a gap on the right side over here. Utilizing some of these alternative implants, zygomatics or pterygoids, are going to allow us to avoid that situation. And so what I ended up doing was something like this. Placed a pterygoid implant on both sides and a zygomatic implant. Now, why did we do this? Let's look at this case a little bit more detail. We're calling this a zygo and ptery rescue case. It's a combo rescue case. If we did not place a zygomatic or a pterygoid implant, we would have a long cantilever by removing the failed angulated implant. Well, we can't really have that because that's going to cause some of the other implants to start having problems. So again, we'd have to shorten the restoration, do sinus lifts, wait for healing, come back, put implants in. So that's one issue that we have. We wanted to avoid a sinus graft. We don't need it because we can place these other style of implants. We don't need the sinus graft. Now, I placed the right pterygoid first. Now, I'm able to hit the pterygoid implant, I'd say probably 98% of the time. In most cases, I get very high torque. Does that mean I get very high torque in every single pterygoid case? No. Ideally, I like to get at least 32. In most cases, I'm getting 50 plus, sometimes 80 plus. But in this particular case, I was only able to get about 30 Newton centimeters of torque. Now, because of this, I went ahead and added a zygomatic implant to support the pterygoid implant. If I was able to get a very, very solid pterygoid, if I got in there and say had 80 torque, was able to get a nice long pterygoid implant, or I may not have placed the zygo, but in this case, because the pterygoid implant was not quite as strong, I placed the zygomatic implant. And then, because we placed the pterygoid on the right side, I went ahead and placed the pterygoid on the left side to balance out the restoration. So it ended up looking something like this. So we used both a zygomatic implant and a pterygoid implant to rescue this case. So how do we choose between a standard zygomatic implant case and a quad zygomatic implant case? This is a question I get quite a bit. So standard zygomatic implant, something like this. And again, pterygoids because I placed zygos, but just one zygo per side. If we're looking for a standard zygomatic case, typically these patients have severe bone loss in the mid to posterior maxilla. They have, again, high occlusal forces, which most people have. They have a need for increased composite torque value, which again, every case has a need for increased composite torque value. We always want as high CTV as we can get. And this is going to allow us to avoid bone grafting. So if we want to avoid sinus lifts, and again, the bone density that we achieve in the maxilla is always higher than what you get with a sinus graft. I don't care how good your sinus graft is. I've done thousands of sinus grafts, really big ones. The bone's never as dense as what you achieve by engaging the zygoma. And so if we're looking at a quad, why do we need a quad? So this case, if we look at the case on the left, it doesn't look that bad. We have bone, but we don't know how thick that bone is. We look at the cross-section in the cone beam, we can see this bone is relatively thin, 3 millimeters or less. Are you going to be able to squeeze an implant in there? No. You can graft this patient ahead of time, a variety of guided bone regeneration techniques, and come back later. Is that bone going to be quite as strong? I would say no. You could use BMP, all kinds of different things, hip, but we can also do a quad. And when we do a quad, we don't have to wait for this bone to heal. We're going to utilize the zygoma. It's going to be very, very dense, very strong. And so quad zygo indications for someone like this, we have extreme bone loss again, which is typically the case with all zygomatic cases. But for a quad, what we need is insufficient anterior bone. So that's basically what we're using a quad, because when we're doing a standard zygomatic implant, we're always placing that first pair of zygos as far posteriorly as we can, because we always want to plan for placing a quad. And when we have that insufficiency of anterior bone, now we can place second zygomatic implants per zygoma and get the support that we need anteriorly. If we have anterior bone, anterior premaxillary bone, we don't need to do a quad because we can utilize that bone for anterior support of the restoration. And we also need a zygoma that allows for placement of two implants. Some zygomas are thick, some are thin, some are tall, some are short. Some zygomas have thickness at the top, but very thin at the bottom. So we also have to look at the zygoma and see if it just has anatomically the size to allow us to place two zygomatic implants. So something that you also need to bear in mind and look at. So let's look at zygomatic implant insertion technique. So what we want to do is a full thickness flap, and I'll typically, and on an edentulous case, do a midline releasing incision. And I will just run that all the way back distally into the hamular notch, because I am looking to typically do a pterygoid implant in these cases. I'll do a distal releasing incision to account for the zygomatic implant. And I try to elevate the flap really nice and clean. Get under the periosteum, get a really nice flap reflection. I don't really want any periosteum on the bone. And I call this a pulled pork flap. I do a lot of barbecue down here in Texas, a lot of smoking. Pulled pork is one of my specialties. I love it. And when I reflect, or I see flaps reflected that the periosteum gets all shredded, it reminds me of pulled pork. I don't want this. When we have a flap, I want it really nice and clean. Don't want to see any periosteum on the bone. Periosteum on the bone, essentially results in a split thickness flap. It gives you a lot of bleeding. It gives you a lot of inflammation, postoperative pain. We get under the periosteum, we get it really nice and clean, very good dissection. And so if we look at this, as we're prepping for a zygomatic implant, we can see it's very nice and clean. There is no periosteal fibers remaining on the bone, or very minimal. That's what we want, Mr. Clean, really nice. And as we are reflecting back for a zygomatic implant placement, you don't want to avoid getting too aggressive posteriorly. I see a lot of people start getting a very aggressive reflection on the posterior maxilla, and sometimes you'll develop a bleed if you're doing this. So you definitely want to reflect to the zygomatic notch to where you can see everything that you need to see, but be mindful of not getting more aggressive than you need to. So drilling protocol. So what I like to do is take a sharp spade drill, and we'll pierce the alveolar crest with this spade, or Lindemann style type of drill. And I'm trying not to enter the sinus if I can avoid it, but if you do, it's not really that big of a deal. And basically what we're creating with this first spade drill is a purchase point. The purchase point for some of the other drills that we're going to be utilizing later. And so here we can see the purchase point that has been created. And once I create that purchase point, I'll usually open a small little window and find the Schneiderian membrane. I'll go ahead and start lifting this. And I'll just use a curette. Sometimes people will just go ahead and blast through the membrane. When you're doing a zygomatic implant, if you tear the membrane, it does heal and doesn't cause problems in most cases. But when we're doing a sinus lift, we try to keep the membrane, Schneiderian membrane, intact. So if I'm doing a zygomatic implant, I'm still trying to follow the same principles. I'm trying to keep the Schneiderian membrane intact, if at all possible. And so our drilling protocol will mark a exit point on the alveolar ridge. We'll connect this to the zygomatic alveolar crest. And typically, if we're doing a single zygo, we are looking for an exit point on the ridge at the first molar or second premolar area. And if we're doing a quad, then we're looking for the second zygomatic implant to hit the crest somewhere around the canine or lateral incisor area. So again, we always want to plan for a quad, even if we're not doing a quad. So if you're doing a single zygomatic implant, start with your posterior position first. And then if you need to do a quad, you have room to do it at the anterior position. Now, if you drill right in the middle of the zygoma, which is very tempting, and typically when you're early in your zygomatic implant career, you'll drill right in the middle of the zygoma because you're just looking to hit it. What ends up happening is if you need to do a quad later, well, no quad for you because you've locked yourself. You don't have any room anteriorly, and you don't have any room posteriorly because you're right in the middle. So again, you want to always plan for a quad, even if you're not going to do a quad. So once we have this initial purchase point prepped, if you've lifted the membrane a little bit, now you can take a diamond drill if you're utilizing the extra sinus technique. And that's my preferred method is I like to do the extra sinus technique. I'll take a diamond drill, create a channel, and you can see that we've exposed the Schneiderian membrane and have kept it intact. And I like to verify this, if I can, with the patient breathing. And now I can go in with my channel drill and prep the remainder of the zygomatic implants channel without worrying about tearing the Schneiderian membrane. So we're going to drill until we penetrate the zygoma. We can either visualize the tilt, palpate it with our finger. You can feel it with a zygomatic retractor as you drill through. The prep diamond slot will help to guide the drill. So it's really nice when you utilize this technique because the drill doesn't end up bouncing all over the place. We'll then go ahead and measure, and we'll take our zygomatic measurement tool. We place that into the osteotomy. The hook will penetrate the end of the zygomatic prep. And then we'll subtract 2.5 millimeters to account for our prosthetic abutment. So we then choose our zygomatic implant, and we go ahead and place that. And I like to place this with a handpiece. Some people use a hand driver. I'll stabilize the shaft of the implant. The implant is going to place. And typically, you'll get very high torque on this. And when you do, you just finish this off with a hand torque wrench. We then select our abutment to fit prosthetically. And then I'll rotate a buccal fat pad to cover any exposed portion of the zygomatic implant. Then do a little bit of soft tissue trimming. And then I'll do suture closure. And I do most of my arch suture closures with a technique I call the Texas two-step. Essentially, this is me using 4-0 chromic suture. And this combination of continuous horizontal mattress and continuous looping sutures. The horizontal mattress sutures evert the tissue, so I get connective tissue to connective tissue. And then it also reduces tension on the incision line. And then the continuous looping sutures compress the tissue at the horizontal mattress site. It also closes any remaining incision lines that may not have closed from the continuous horizontal mattress. Very nice, clean technique. You don't get a lot of tails everywhere. There's essentially just one tail where you start and close and tie up the suture. So when you're doing your pickup, you have less chance of acrylic picking up any of your suture tails. So very nice, clean technique. And I talk about this in the pterygoid implant book. So we talked about pterygoid implants. We talked about zygomatic implants, how you do them. Now, how does Amnion-Chorion fit into all this? How do I use this particular material in my practice? So first of all, what is Amnion-Chorion? It's a short name for it is DHACM, Dehydrated Human Amnion-Chorion Membrane. Essentially what we're talking about is BioXclude. BioXclude sold by Sinus Medical. And what this is, it's derived from the Amnion-Chorion, which is placental tissue. It's avascular tissue comprising the innermost layer of the placenta that separates the mother and the fetus. And if we look at this, we can see that it has tons of collagens, type 3, 4, 5, has laminins, fibronectins, proteoglycans. If we look at how this is configured and processed, this tissue comes from consenting mothers that have C-sections. And this placental tissue, it is deepithelialized, the spongy layer is removed, and then the amnion and chorion membrane are laminated together to form DHACM. And some important things to consider with this is the denuded epithelium. So removal of epithelial cells hastens cell migration compared to products that are non-denuded, that don't have the epithelium removed. So this is one benefit of BioXclude that utilizes the Chorion processing technology. Amnion-Chorion in BioXclude has over 200 preserved growth factors, cytokines, and chemokines. So tons of natural growth factors. We're utilizing a number of different biologics in bone grafts. With this particular material, they're naturally in there. Placenta is where life begins. There's tons of growth factors here, and they naturally come with the product. You don't have to buy it extra, it comes with it. So there are some benefits and some significant benefits of Amnion-Chorion being combined. There are a number of dental products that are coming onto the market, following in the footsteps of BioXclude. But most of these products are Amnion only. And there are some significant benefits to Amnion and Chorion being combined. And also there's benefits of how they're processed. So with many of the other processing technologies that just have Amnion, they're only retaining a small percentage of the growth factors if you're just having Amnion. If you're using the Chorion processing technology, which is what BioXclude is processed with, from a company called Mimetics, we retain about 20% of the growth factors with Amnion. Now, if we combine that with the Chorion, we now have close to 100% of all the growth factors available to us from this placental tissue, from the Amnion and Chorion. So why is the Chorion making such a big difference? Well, benefits of combining these two is, DHACM, which means Amnion and Chorion, have 20 times more growth factors than Amnion-only grafts. And the reason for this is the Chorion accounts for 80% of the growth factors found in dehydrated human Amnion-Chorion membrane. So for DHACM, you're getting the bulk of your growth factors in the Chorion. And so if you have just an Amnion-only product, you're missing out on tons of growth factor. You're missing 80% of the growth factors. The other thing is when you have Amnion-Chorion, the combined laminated product is 4 to 5 times thicker than Amnion-only grafts. So it makes it much easier to handle, much easier to use, and you get all the benefits of the additional growth factors. If we look at Amnion-Chorion membranes versus traditional porcine collagen membranes, we can see that porcine collagen membranes, there's no growth factors in there. It's designed, collagen, keep things out. Where Amnion-Chorion membrane, again, has tons of growth factors. It's designed to act more as a biologic than a simple barrier that collagen membranes function as. Another nice thing with Amnion-Chorion is angiogenesis. So if you remember back in residency, that if you were asked a question, you didn't know the answer, if you said blood supply, you'd be right half the time. Well, if we have a product such as BioXclude that can give us angiogenic growth factors, that's going to enhance our healing. And so utilizing the Amnion and the Chorion, we have a variety of different growth factors that are angiogenic in nature. So it's going to help our grafts, it's going to help our healing. And the release of this, we're still doing more studies on this, but we know there is a release of this over at least a 96-hour time frame when we place these growth factors, in the body with Amnion-Chorion. We're getting angiogenic growth factors. We're getting growth factors that help tissue healing, such as laminin, laminin 5. That's going to allow faster soft tissue closure of our graft. We have PDGF. We have a variety of factors that are going to help bone healing. And so this happens early on in the initial healing process. So Amnion-Chorion has been used in medicine for well over 100 years. Placental tissue in medicine is nothing new. Some of the first studies on this were published in 1910 in a review of 550 skin transplantation cases at Johns Hopkins. In the 40s, this was used for treatment of conjunctival epithelial defects. It was used in the 60s for ENT surgery. And even back then, what they noticed in all these studies was that when they used placental tissue, there was a lack of infection, that there was decreased pain with their patients, and an increased rate of epithelialization. And so more recently, within the past 20 years, Amnion-Chorion tissue has been used very extensively in medicine for treatment of non-healing diabetic ulcers. And the results that this product has achieved for this type of problem has been dramatic. And so we've seen an explosion in use of Amnion-Chorion for treatment of non-healing diabetic ulcers in medicine. It's also being used for prostate neurovascular bundle wraps in prostate surgery. What they're finding is improved return to continence times by over 50% and improved erectile function return by over 90% by simply wrapping the nerves with Amnion-Chorion tissue. It's being used in Mohs micrograft surgery. And you can see these are pretty dramatic results. We think of a little connective tissue graft in anterior maxilla, being highly aesthetic. We'll think about having to do something like this. You can't really hide this behind a smile. It's there for the world to see. And Amnion-Chorion tissue, because of all the growth factors that are inherent with it, can help the healing here. And that's very understandable. So Amnion-Chorion use in dentistry. Well, we've only been using this in dentistry now for about 12 years. I started using this product when it first came out. It was around 2008, 2009. And we used it for a variety of different applications in dentistry. Initially, it was just used for treatment of recession defects. But as time went on, we utilized this product for more and more things. We utilized it for site preservation, guided tissue regeneration, treatment of periimplantitis, guided bone regeneration, sinus lifts, repair of Schneiderian membrane. We've even used it now for treatment of nerve injuries, iatrogenic, injury to the inferior nerve. It's being used in treatment of temporomandibular disorders. It's being used in as a filler for endodontic treatment. It's being used for a variety of different applications in dentistry. But how are we using this for Amnion-Chorion product for pterygoid implants and zygomatic implants? Well, let me show you how I'm using it in my practice. So many times when we're doing an arch case, if we're going to utilize pterygoids or zygomatics, we have potential for sinus exposure because we have to do bone reduction. And if we have a case like this, and this is our anticipated bone reduction line, you can see where the sinuses drop from the pneumatization, that there's a good chance we're going to enter into the sinus. And so as we do our bone reduction here posteriorly, we can see that we have entered the sinus. So I go ahead and lift the Schneiderian membrane. And we can see we have a little bit of sinus perforation, but that's not a problem. We can use our Amnion-Chorion membrane to repair that very easily. And so that's what we did. We take a little bit of BioXclude, we place that directly onto the Schneiderian membrane. And I like to place it dry because it's much easier to handle when it is dry. And then hydrate it with saline, or you can use blood. And when the BioXclude hydrates, it becomes tacky. It's self-adherent. It will stick to the Schneiderian membrane. It seals the perforation. Now I can go ahead and graft. And then I can place another layer of BioXclude to cover what we essentially have as a crestal window from our bone reduction process. And then close with the Texas two-step suture, which is what I use for most all arch closures. And here's the patient before, and here's the patient immediately after, and the patient before and after. And this patient was treated with a FAST technique utilizing pterygoid implants. And we can see where we had the essentially crestal sinus lifts, where we had the sinus exposures during the bone reduction. So we have two small areas of sinus lift, and that's just providing a little bit of a distal wall to the angulated implants And then we have our pterygoid implants behind that to give us the benefits of the pterygoids that we discussed previously in the lecture. So this is what we end up looking like. You can see the significant increase in the AP spread. You can also see the significant increase in composite torque value by placing the pterygoid implants. Let's look at utilizing this for a zygomatic and pterygoid case. And so in this particular case, we have thin bone anteriorly where the bridge pontic is. We have very close root proximity. And that's the big problem with this case, because the roots are so close together. When we take out the teeth, there's not much bone left. And this patient had a lot of tooth mobility because of this. And that's one of the reasons that they were seeking out this treatment. We have retained third molars. The retained third molars are going to make placement of pterygoid implants a bit more difficult because there's less bone at the pterygomaxillary complex when this happens. And so we go ahead and do our zygomatic prep, and we see our channels. We go ahead and use our drills, place our zygomatic implants. Now, when we look, we can see that there is a little bit of sinus perforation, Schneiderian membrane perforation here next to the zygomatic implant. And so what we go ahead and do is take some BioXclude Amnion-Chorion, place that directly onto the sinus membrane perforation, place it dry, as I mentioned before. It self-hydrates, or you can utilize some saline from your assistant. And now the Amnion-Chorion membrane becomes tacky. It self-adheres to the Schneiderian membrane, and now we can graft that and then rebuild a little bit of that bone. And then I'll put a layer of BioXclude over the top of that, and then advance a buccal fat pad to cover the external portion of the zygomatic implant, as we discussed earlier. Again, close with a Texas two-step suture, and this is what the patient looks like afterwards. So this is as we discussed earlier in the lecture, a standard zygomatic implant technique. And again, if I'm placing zygotes, I'm placing some pterygoids to give them support. And as you see, I was able to get a few implants up in the front, so we didn't need a quad. And this is what it looks like from the side, nice and parallel. And let's look at another case, zygomatic and pterygoid implants. So in this particular patient, we have some old snap-on style implants that are starting to go bad, and the patient is desiring a fixed solution. And so we go ahead and do our flap for our zygomatic implant. And in this particular case, I found the internal branch of the posterior superior alveolar artery, which we many times find in doing sinus lifts or zygomatic implants. So if I find it, I'll go ahead and dissect that out, tie it off, just so there's less bleeding. Sometimes that can be a pain during the surgery. So we tie it off. Now we can cut through it, and we go ahead and finish our prep. We've kept the Schneiderian membrane intact on this side. Do our drill, place our implant. On the other side, in preparing for the zygomatic implant, we have a sinus perforation on the left side. So I go ahead and take a piece of BioXclude. You can see again, I have it nice and dry. We will place that into the zygomatic channel prep over where the perforation is, and then utilize blood or saline to hydrate the membrane, and it will now stick and self-adhere to the Schneiderian membrane. And now I can continue with my drill prep and place the zygomatic implant. And so that's what we do. Place the implant, rotate buccal fat pad, close up with a Texas two-step, and you see it's really nice and clean. And now we can continue with restoring the case. And so here we have patient before and after, and you can see that this was just a standard zygomatic pterygoid technique because we were able to get some implants anteriorly. And again, we have the pterygoids in the back to support the zygomatics. And this is what the patient looks like laterally. And let's look at one final case. So this is an interesting case, and we're utilizing BioXclude for treatment of a failed zygomatic implant. So in this particular case, we have a referral for a failing zygomatic implant, and this patient essentially ended up having undiagnosed sleep apnea, which caused bruxism, which ended up causing this zygomatic implant to fail. And so we got the sleep apnea treated, which also reduced the bruxism. And you can see, though, there was a significant defect in this zygoma. And so if we look at a 3D view, we can see the defect from the zygomatic implant. And so we go ahead and remove the zygomatic implant, clean out the defect, and we can see a nice, well-contained defect in the zygoma. And fortunately, there was enough bone remaining that we were able to place a second zygomatic implant away from the defect, and then went ahead and grafted the defect and utilized a combination of allograft and xenograft here. And then I used a double membrane technique where I put the Amnion-Chorion BioXclude tissue and then essentially laminated that to a collagen membrane. I utilized the Amnion-Chorion on the inner aspect of the membrane because that was closer to the sinus, and we also had the failed zygomatic implant, so we had a communication tip sinus. So I utilized that on the interior, and then a collagen membrane on the exterior, just to provide a little bit of space maintenance, because the BioXclude membrane is fairly thin. It's about 300 microns. So to give a little bit more space maintenance support, we're utilizing a collagen membrane on top of the BioXclude membrane. Then rotate the buccal fat pad, close with the Texas two-step suture. And here we are before, and here we are after during the healing process. In this case is about 6 months out or so in its healing process, maybe a bit further out at this point. But here's a 6-month scan. And we look at before, you see a very large defect. Here we are at a week follow-up, and here we are at about 6 months. We see the defect is healing very nicely. And if we look at before in a 3D view, at a week, and here we are at about 6 months. So we can see that that defect in the zygoma is healing, and our new zygomatic implant is healing very nice and stable now, and we were able to utilize our Amnion-Chorion to help treat this defect. So that puts us at about time up for this lecture of utilizing Amnion-Chorion BioXclude membrane for treatment adjunct with zygomatic implants and pterygoid implants. Again, you can find more information about zygomatic and pterygoid implants in my textbook at pterygoidimplantbook.com. And we're going to now open the floor for any questions that you might have. And I'd like to thank you for your attention and wish you a good rest of the day. Thank you.